Fertility New Zealand is a registered charity. We've been helping Kiwis with infertility for more than 25 years. We provide a range of resources, information such as fact sheet leaflets, which go into all of the clinics, information videos on our website. We have an 0800 line. And importantly, we have support groups all around the country in 12 different centres. They're run by volunteers who have typically been through their own fertility journeys, and they offer regular meetings, often with guest speakers and things as well. We also offer advocacy where we represent the voice of New Zealanders with infertility, both on an individual level and on a governmental level. The Fertility Week campaign has been running for a few years now, and that's our only activity really, which tries to reach people who may be affected by infertility in the future, as well as people who are currently affected. So the week is drawing to a close today, and tonight is the final webinar on fertility treatment. And it's my absolute pleasure to introduce Dr. Guy Gudex, who is Medical Director of ReproMed Clinic in Auckland. I'll just hand over to Dr. Gudex in one moment. If you have any questions, please feel free to type them into the box during the presentation. And Dr. Gudex will either answer them at the time or save them till the end, as best fits the flow of his presentation. Thank you very much.
Well, thank you very much, and welcome to this overview of fertility investigation, diagnosis and treatment. It's quite a big topic, so I'll do my best to highlight the important points. I'll probably talk for about 15 to 20 minutes, and then there'll be time for questions afterwards. In terms of the most common problems that we see in couples presenting with subfertility and patients presenting with subfertility, endometriosis probably accounts for about 10 to 15% of cases. We see a male factor in up to about half of cases, and clearly infertility can be multifactorial. So what that means is that there may be a male factor and a female factor together at the same time. We often find at least even a mild male factor in about half of cases. Polycystic ovary syndrome's had a reasonably high profile the last few years. This is a syndrome that affects ovulation. And probably 20% of the cases that we see involve polycystic ovary syndrome. Recurrent pregnancy loss or recurrent miscarriage is also a reasonably common presenting feature. And finally, unexplained infertility, which probably only about 10% of couples are now diagnosed with, as we've got better at diagnosing particularly sperm issues. In terms of endometriosis, the only way that endometriosis can actually be diagnosed is by laparoscopy, which is an operation putting a camera in through the tummy button. Endometriosis can be completely asymptomatic, although many of you will be aware that painful periods is often a clue that endometriosis might be present. And when we investigate a woman who presents with subfertility, we find endometriosis in up to about 20% of the cases. Endometriosis can be treated quite effectively surgically, and we know what it is, we just don't know why women get it. So we know that it is basically the cells that line the uterus growing outside the womb, and in the rare cases can block the tubes, but usually is just causing implants around the ovarian tubes that we think interferes with fertilization and possibly implantation. When we diagnose endometriosis, we have several treatment options. Lopidol's had quite a lot of publicity in the last few years. The initial study was done about 10 to 12 years ago at National Women's Hospital here in Auckland. It involves flushing the tubes with a preparation that includes extracts from poppy seed oil. We're not completely sure how it works, whether it's simply a tubal flushing or whether it also has an effect on the lining of the uterus, on the endometrium, to improve implantation. But a big follow-up study last year from Europe confirmed the original findings from 10 to 12 years ago. And Lipidol tubal flushing can probably double the chances of getting pregnant over the following 6 to 12 months. Intrauterine insemination is used a lot in New Zealand. If mild endometriosis only is present, it can be effective. Obviously, you do need to have patient's tubes because the sperm is put up into the uterus, into the tubes at the time of ovulation. And again, in New Zealand, we often use clomiphene when we're doing intrauterine insemination to make an extra egg or two. That raises the issue of twin pregnancy. And we know that with clomiphene, the risk of twins is about 7 or 8% if the woman's aged under 35, and it's 3 or 4% if the woman's aged over 35. We use ultrasound scans and blood tests to minimise that twin risk. IVF's obviously used also where endometriosis has been an issue. And IVF is involving extracting eggs and adding sperm and putting a fertilised egg back into the uterus. And unless the ovaries are significantly affected by endometriomas or chocolate cysts, generally endometriosis won't negatively impact significantly on IVF success rates. Laparoscopic surgical removal of endometriosis still remains probably the gold standard and will significantly improve the chances of spontaneous pregnancy. We're always careful when we deal with chocolate cysts, which is endometriosis in the ovary, to try and limit any damage to the remaining ovarian stroma that contains the eggs. And many of you will be aware of a helpful blood test called AMH, anti-Müllerian hormone, which we can do to check a woman's ovarian reserve because it's a hormone that's produced by eggs. And we will nowadays usually do an AMH before surgery, and then 6 months later or 4 months later, recheck the AMH to make sure that the surgery hasn't had any significant impact. And then there are also some alternative options for treating endometriosis, including herbal treatment. In terms of what can you do to help yourself, age is often mentioned as a really important issue in terms of future fertility. So we know that for many women by the age of 28 to 30, the decline of egg numbers starts to accelerate. And there was an article in the Herald a couple of years ago saying that if people would like 3 children, say, they probably need to start at 26 or 27 years of age to give themselves several years in which for that to happen. In New Zealand, average age starting first child is usually about 30 years old. And age is probably one of the biggest issues that we face, as on average in New Zealand, women are 36 or 37 years old, for instance, when they undergo IVF. And we know that already by that age, success rates are less compared to in late 20s and early 30s. It's important also to consider some environmental effects, and there's been publicity again about limiting exposure to xenoestrogens. Optimizing BMI is really important, and that's both for men and women. And there's increasing evidence that for men who are significantly overweight, testosterone can be affected and sperm parameters can be affected. For access to government-funded treatment, which I'll mention at the end, there's currently a BMI cutoff for women of requiring to be under their BMI of 32. And we know that losing weight can also optimize ovulation. Exercise is helpful and important. Important to not over-exercise, which is probably intense exercise for more than 40 to 60 minutes a day, but equally moderate, low impact, low intensity exercise is very good for you and will improve blood flow. There's been a lot of interest in acupuncture. There is some evidence that acupuncture will improve fertility naturally. There's less robust evidence about acupuncture benefits before and after IVF. Male factor, we see in up to half of cases of couples presenting to us Sperm over the last 60 or 70 years has declined in quality. And at the moment, the WHO, World Health Organization, stipulates that a count of 15 million per mil is the lower limit of normal. But it's probably helpful to understand that 30 years ago, it was in fact double that, at 30 million per mil. So there's been a progressive decline, and that's probably largely environmental factors. The treatments we usually use for male factor, if lifestyle modification isn't effective, will usually be intrauterine insemination or IVF. In terms of the chances of pregnancy with sperm issue, if the sperm count's less than 5 million per mil, it's very unlikely that spontaneous conception will occur. But with all people who present to us, we look at several factors, including how many years infertility has there been, is there any previous pregnancy history, and also, as we've mentioned before, female partner's age. We always repeat the semen analysis at least once because we don't want to make serious decisions based on a single result. And about 10% of men will have quite a variable sperm count. We also advise couples who are trying to conceive and men who are trying to conceive for the men to take antioxidants generally. There are several preparations on the market, such as Vitamins, Menavit, Proconceptia, that contain a variety of antioxidants. They include zinc and selenium, folic acid, vitamin C and E. And these things all work to improve sperm genetic health and improve sperm parameters. And certainly any couples doing intrauterine insemination or IVF, we recommend that the man's on antioxidants. We'll also do some other blood testing if the semen analysis is lower than about 5 million per mil. That might include a chromosome check, a cystic fibrosis gene mutation check, and also some check hormone levels, including FSH and testosterone. We'll do a detailed history. We'll ask about a history of testicular trauma, torsion, hernia operation, and obviously ask about previous vasectomy, which an increasing number of men will present with. Physical examination is important, including looking for a condition called varicocele. Varicocele is a little bit like a varicose vein in the testicle, and there are surgical and radiological treatment options. And on occasion, it's been demonstrated that treating the varicocele will improve the sperm parameters. Unfortunately, a lot of causes of sperm problems are unknown. We're aware of a few, such as obstruction or blockage of the vas by previous infection. The epididymis can be blocked by previous infection. And there's also a condition where men are born with a mutation that they've inherited of the cystic fibrosis gene, and that can result in a little bit of the vas missing. We can usually tell if obstruction is the problem by clinical examination and doing some blood tests, and a testicular biopsy will confirm that sperm is present and we can freeze that sperm. We've talked already about obesity. Lifestyle modification, including giving up smoking and reducing alcohol, is always important. And we see an increasing number of men with vasectomy regret who are in a new relationship. Vasectomy reversal can be done. There's often a problem afterwards with what we call anti-sperm antibodies, which cause the sperm to stick together. And so a significant number of men after a vasectomy reversal will need to do IVF with microinjection, which is injecting the sperm into the egg. And some couples opt to just go straight to IVF ICSI rather than the vasectomy reversal because they want to avoid surgery or because of the anti-sperm antibody issue that I've mentioned before. There's some evidence around the importance of avoiding laptops on your lap, cell phones in your pocket, and chronic exposure to heat. In terms of treatment options for sperm problems, on rare occasions we can add in some hormone replacement to improve the sperm count, and that's usually where there's a pituitary abnormality. Those cases, unfortunately, are reasonably rare, and quite often, rather than being able to improve the sperm count significantly, we have to look at options like intrauterine insemination and IVF. You need a pretty reasonable sperm count to do intrauterine insemination, And so ICSI, which came in the mid-1990s, has revolutionised what we've been able to do with IVF. So a single sperm is picked up and injected into the egg. And prior to the introduction of ICSI, we needed to offer couples donor insemination, unfortunately. There are also some further methods such as high magnification sperm selection, PIXI, which is physiological selection of the best sperm to use for ICSI to try and optimise fertilisation. We've talked about some of the lifestyle changes for men, managing stress. There are certain prescription medications that you need to be careful about that might affect sperm counts. And we always look at medical problems such as diabetes if a man presents with a abnormal sperm parameter. There's evidence about declining sperm health with age, and certainly we don't accept sperm donors over the age of 45. Again, moderate exercise is sensible, and we've talked already about the use of antioxidants. Polycystic ovary syndrome is a presenting feature of about 20% of couples that we see. It's diagnosed primarily on an ultrasound scan, and the AMH blood test that I mentioned earlier can also be very helpful to confirm the diagnosis, because usually if polycystic ovary is the problem, AMH is significantly elevated. The clues to polycystic ovary are usually an irregular period or an absence of periods, and also unwanted hair growth and also acne. We will have some couples presenting for IVF because of a sperm problem who might also have polycystic ovary, for instance. But generally speaking, if the only problem is polycystic ovary, then we can treat it pretty effectively by first of all advising weight loss if weight is an issue, and then also using an ovulation induction agent called letrozole. Letrozole's really replaced clomiphene, which we used to use, primarily because it's more effective, and also there's a significantly lower risk of twins. Letrozole is very simple to take. You take it for 5 days when the period comes, and probably half of the time we also add in a drug called metformin, which is an insulin sensitizer and will help response to letrozole. So we can get quite a few people to ovulate normally and get pregnant just using those simple treatments. Clearly, on occasion, we need to resort to IVF, and if we need to do that, we do manage the drug dose carefully, as hyperstimulation syndrome is a possibility. But as I'll talk to a bit later with IVF, we can now very effectively manage the risk of hyperstimulation syndrome, and now it's a very rare thing. We've talked about weight loss if obesity and polycystic ovary is an issue. There's a lot of information now out in the community about weight loss diets and also low glycemic diet. Again, I emphasize the importance of regular exercise. Probably the right mixture in terms of looking at weight loss is 75% calorie intake and 25% exercise. Recurrent pregnancy loss is a reasonably common problem. It's defined as 3 or more consecutive losses, and that can include an ectopic pregnancy, so it could be 2 miscarriages and an ectopic. And unfortunately, although we have some investigations that we can do, we find a cause for the underlying recurrent pregnancy loss only in very rare occasions, probably in well less than half of instances. There are, however, things that we can do to manage it. Investigation's important, so we'll do an ultrasound scan or an MRI to rule out any problem with the uterus, such as a septum or fibroids. We'll do some immune screening and thrombophilia screening, and we'll also do genetic screening, including chromosomes on both partners. As I said, quite often we don't end up with any underlying cause, but it can actually be quite reassuring just for a obvious problem to be ruled out. And we know that supportive care within the setting of an early pregnancy clinic can actually make quite a big difference. There will be occasions where we recommend endometrial biopsy to try and see if there's a identifiable implantation issue. And we'll also always check ovarian reserve, because occasionally people presenting with recurrent pregnancy loss will in fact have quite a significantly low ovarian reserve, and time is really becoming an issue. Again, in terms of self-help for managing recurrent pregnancy loss, there's been discussion already about antioxidants for men. There's some evidence that antioxidants for women, and they include multivitamins, CoQ10, melatonin, omega-3 oils, can have a beneficial effect on egg genetic health. And we know that the contributors to miscarriage are probably about 3/4 of the time the embryo, which could either be an egg or a sperm problem or both, and about 1/4 of the time the lining and implantation. We've talked already about stopping smoking and optimizing weight and maintaining a healthy weight range. Counselling and supportive care can also be very important. Unexplained infertility can be very frustrating for couples. Essentially, it means that the tubes have been investigated, endometriosis has been ruled out, ovulation doesn't seem to be a problem, and as far as we can tell, there are normal sperm parameters. And about 10% of couples get diagnosed with unexplained infertility. That has reduced from previous years because AMH has allowed us to pick up women where we actually think reduced ovarian reserve as part of the problem. Prior to AMH being available, we had a day 2 to 3 FSH blood test that we could do, but that was a reasonably unreliable marker of ovarian reserve, and AMH has been a real improvement in our ability to predict what the next few years hold in terms of egg reserves, and also giving recommendations about when it might be appropriate to introduce some treatment. Treatment options for unexplained infertility include the lifestyle changes that we've talked about may be sensible. Intrauterine insemination can be used if there's a desire to. And in New Zealand, intrauterine insemination is used quite a lot because it's much cheaper than IVF and has quite a success rate cumulatively over 3 to 4 cycles, probably equivalent to 1 IVF cycle. We've talked about Untitled tubal flushing also. In terms of expectant management and lifestyle change, we've talked about Untitled. Laparoscopy with tubal patency flushing can be useful, and minimising caffeine to 1 or 2 a day is sensible. In terms of intrauterine insemination and IVF ICSI, some couples will opt to go straight to IVF ICSI. Part of the reason for that is it is the most effective single treatment, and over the last 10 years or so, IVF has certainly got quicker and simpler and safer, and that's largely with the introduction of what we call antagonist cycles. They've also allowed us to virtually eradicate the problem of hyperstimulation syndrome, so that even if we get 15 or 20 eggs, we have a different trigger that we can use, and we can absolutely minimise the risk of someone ending up with that syndrome. It's essentially where the ovaries swell up, there can be a lot of free fluid in the tummy, and in extreme situations people end up in hospital. It's now a very, very rare occurrence. In terms of microinjection, in New Zealand about half of couples end up using ICSI as an addition, and usually that's if there's a very clear sperm issue identified. We'll occasionally recommend microinjection if there's 5 or more years of unexplained infertility, and we're concerned that there may be an undiagnosed sperm issue. You'll be aware that with IVF in New Zealand, single embryo transfer is utilised probably about 96–97% of the time. And I'm pleased to report that in New Zealand now, the twin pregnancy rate from IVF is right down at about 3%. And we've achieved that by most of the time just putting 1 fertilised egg back. I think it's fair to say that New Zealand and Australia have really led the world with that. In terms of treatment success, it's very age dependent. And so with intrauterine insemination, if a woman's under 40, we would expect success rates of around 10 to 12% per cycle, and that will drop once a woman becomes over the age of 40. We would expect about a third of couples to get pregnant and have a baby if they do a package of 3 to 4 cycles of IUI. In terms of IVF, as I mentioned before, the average age of women undergoing IVF in New Zealand is about 36, 37. And the pregnancy rate per embryo transfer, if you're under the age of about 37 or 38, is about 35 to 40% per embryo transfer. And that's slightly better, paradoxically, with frozen embryos. The reason for that is possibly that in a fresh IVF cycle, there's a bit of an impact on the lining in some patients. And so we've found that in about 30 to 40% of cases now, we freeze all embryos and put the first one back a month or two later, once the ovarian enlargement is settled down. It's important to note that once a woman becomes 43, 44, the chances of success become quite low, and several cycles might be required to give a reasonable chance of pregnancy. Remember also that IVF and IUI don't guarantee a normal embryo, and so miscarriage is still a risk with treatment pregnancies. And there are now options with IVF, for instance, to have embryos genetically tested prior to reinsertion, and that's been demonstrated to reduce the miscarriage risk quite significantly. Ovarian hyperstimulation syndrome is largely a thing of the past. So we on purpose hyperstimulate the ovaries for IVF. But because we use antagonist cycles 90 to 95% of the time now, if we think that we're going to get more than 10 to 15 eggs, we can give an alternative trigger and on purpose freeze all of the embryos that we get. And that virtually prevents the risk of hyperstimulation syndrome. AMH has also allowed us to predict quite effectively who's at particular risk, and those primarily are the patients with polycystic ovary syndrome. I've mentioned already about the risk of miscarriage, and obviously there's also the emotional impact of treatment. We recognise that, and counselling is available before and during treatment if required, and all of the multidisciplinary staff are skilled in offering supportive assistance. I just want to finish off by mentioning about public funding in New Zealand. There is unfortunately a waiting list in most parts of the country of over a year for publicly funded treatment, and access to IVF and intrauterine insemination through the public system is determined by a reasonably complicated scoring system, but essentially women need to be under the age of 40 and have a BMI of less than 32 to be eligible. You need to have been trying for over 4 years to get enough points if you have unexplained infertility, and otherwise you need a reasonably serious cause such as grade 4 endometriosis or a serious sperm problem, blocked tubes, to be able to qualify after 1 year. Couples are entitled to 2 lots of treatment, 2 packages of care, which could be 2 IVF cycles, and currently the funding is for biological infertility. This means that if a woman, for instance, is doing donor insemination in the same-sex relationship or a single, then 6 cycles in an accredited clinic need to be performed prior to becoming eligible. Thank you very much. That's covered quite a lot of the diagnosis and investigations for infertility, and I've also given a summary of the commonest treatments, which include intrauterine insemination and IVF. I'm now happy to answer any questions that people might have.
Doesn't look like there are any questions tonight, Dr. Gudex. So we will sign off there, and thank you very much for presenting tonight's webinar on fertility treatment.
Pleasure, thank you.
Thank you. Good night, everybody.